has led and participated in drafting a number of policy documents in the country, including the National NCD Strategic Plans, the National Multisectoral Nutrition Action Plan, the National Health Sector Strategic Plan. She is currently the co-chair of the Tanzania Medical Association of Tanzania National Council, and board member of the Tanzania Human Genetics Organization, and co-chair of the Tanzania Young Academy for Science. Mary also serves as a visiting lecturer for higher learning institutions and supervises a number of students for masters and PhDs. Dr. Maige has published several peer-reviewed publications, and this afternoon she will talk to us regarding the historical perspectives, current situation, and recommendations on primordial and primary prevention of NCDs among people living with HIV in Tanzania. Please join me in warmly welcoming Dr. Mary Maige.
Okay. All right, thank you very much. Do I have a pointer or anything? Okay, I think in the interest of time, I've been thoroughly introduced, so can we please go to the my next slide? So I'm going to talk about the burden of NCD and prevention strategy in general that also applies to in the HIV population. And throughout my presentation, I'm going to give a background of where we are, what is the current burden of NCDs in Tanzania, and highlight the comorbidities that exist between infectious and non-communicable diseases, and what we need to do to expand prevention of, as you said, primordial and primary prevention of NCDs. Next slide, please. This is a slide that I put just to highlight the burden of NCDs globally, and we can see that even at the global level, we are shifting from primarily infectious diseases to having comorbidities that are mostly non-communicable diseases. And so this is the global picture, but we are somehow almost seeing the same things in developing countries. Next slide, please. So this is a slide that I borrowed from the Tanzania NCD strategy, and it highlights the picture that we saw from the first slide at the global level, and it's the same thing that is actually happening also in Tanzania. And we can see that although we still have infectious diseases like HIV, diarrhea diseases, and the like, but we're seeing a shift in the epidemiology of diseases, and we're going more towards, we have diseases that are secondary to infections that are going down, but then we're seeing NCDs actually going up, and I think that is expected with the good work that is being done in HIV programming and maternal and child health. So we should expect also the change in epidemiology, and we have to be aware and make sure that our system is also changing according to the change in epidemiology. Next slide, please. So this is just another slide showing an increase, and this is specifically for cardiovascular diseases, and we can see in developed countries they have managed to plateau, and now the burden is slightly decreasing, but for developing countries, this is the opposite. These diseases are increasing. Next slide, please. So I particularly like this slide. This is some of the work that we've done. This is part of a report that we did to summarize the burden of NCDs, and it was published in 2020. And we can see that I think the first ideology was that NCDs are diseases of old people, and this is not the case. So we should be aware that we have a huge scope of non-communicable diseases, and these are prevalent across all the age groups. So we can see primarily we have infectious communicable, maternal, and neonatal and nutritional issues in the early years, but you can see NCDs are consistent across all the age groups. So when we go to our programming, we shouldn't forget that the young ones, they suffer from other NCDs, but we should be aware that that exists. Next slide, please. And so what are the risk factors for non-communicable diseases? We're used to seeing, those of us who are working in NCDs, we were initially talking about 4 risk factors and 4 diseases, but we know now that the scope is beyond that, and we have non-traditional risk factors that we're talking about. And some of them actually are to do with nutrition, and some of them, it is beyond the behavioral risk factors that we currently are talking about. So next slide, please. I put this slide just to appreciate the interaction between non-communicable diseases and poverty issues, and as well as access to care issues, and also infectious diseases. And we can see that in your population that you serve, actually this is even more relevant, because you have the population that you serve are more exposed to some of the infection and the inflammatory processes that are ongoing. So we need to be cognizant when we are now intending to go into programming for NCDs within our population, to make sure that we analyze the data that we have and to identify what are the major drivers of the NCDs that you see in your population. You might invest in risk factors that are actually not relevant in your population. So next slide, please. In our population, we know that the current drivers for NCD deaths in Tanzania is actually cardiovascular diseases, but I just want to bring this to your attention that we're actually in the epidemic transition, so we need to focus on cardiovascular disease, but also be aware of infectious causes, but also hypertensive-related diseases, which the main risk factor is actually inadequate access to care. So we might need to also have a look at that before we go to address obesity and all these other causes that are commonly talked about. Next slide, please. So how do we prevent cardiovascular diseases? Next slide. So they provide primordial, primary, and secondary prevention. I won't dwell into that in the interest of time, but next slide, please. So I just want to highlight this slide. Why do we need to tackle this epidemic from all angles? We need to describe the population that we have and identify the levels of risk factors. And as a primary preventive measure, we need to focus on looking at the entire population, but then we need to have measures to identify those at high risk that are at the far end of the distribution, and make sure that you have individual intervention that targets individual patients according to the profile of risk factors. Next, please. So we might need to implement population-level interventions, but also at the individual level, to have measures to identify those at high risk and address the risk factors, but also the systemic issues, the system issues, to be able to adequately address the burden of NCDs. Next slide, please. So what are the risk factors in Tanzania? This is the data from detailing the risk factors that cause the majority of the burden of NCDs, burden of disease in Tanzania. So we shouldn't just address overweight, obesity, and physical inactivity, but we also have to look at what risks are actually driving the burden of disease in the country. And when we're talking about risk-based approach, we need to address all that to be able to adequately address the disease burden in Tanzania. And why risk factors are important, we can see all diseases, as the risk level increase in your population or at the individual level, you increase the risk of getting these diseases. So we need to make sure that we shift the entire population to lower risk levels, and in the end, reduce the burden of NCDs in the country. Next slide, please. So this is just to say that we have to take a life course approach. So there are risk factors before even somebody is born. So the maternal factor, the environmental factors, there are risk factors that somebody accumulates across the lifespan. So we shouldn't only address NCDs in adults, but also from childhood, addressing nutritional issues, addressing maternal health, and addressing nutritional issues among before conception and all that, and also addressing the food system and the entire environment, because all that affect the risk of NCDs. Next slide, please. So maybe I don't have time to dwell into that, but this is one of the resources because, as I said, majority of the risk, the cause of mortality and morbidity is actually cardiovascular diseases, and this is one good resource that details how the screening can be done, and we might discuss that further in detail. Next slide, please. So this is one of the studies that we looked at the data from our previous national survey, and what it's showing us is that we're actually screening, but we're not screening the people that needs to be screened. And so we need to make sure that we address this in our programming to make sure that we have a good way to identify those at risk and make sure that those identified high-risk population are addressed with the right interventions. Next slide, I would like that to be the last. Next slide, please. So this is just a scoring system. One last slide, and then I'll stop there. Next slide. Next slide. Yeah, so this is our cardiovascular risk profile for Tanzania, but I don't want to go to the next one. Also, we have identified, but then we are not treating the right people. So those that are identified high risk are not the ones that are reached by the intervention. It's talking about the same thing about screening. So I think I'll stop here. We'll have more dialogue. Unfortunately, there was confusion of the timetable, so I'll go and make a presentation in another session, but I'll be back for the Q&A. Thank you.
Thank you so much, Dr. Mary, for that elaborate presentation. The next speaker is my teacher, Professor Kaushik Ramaiah, a member of the board of the World Diabetes Foundation, Honorary General Secretary of the Tanzania Diabetes Association and Tanzania NCD Alliance, President-elect for the East African NCD Alliance, and member of the board of the Global NCD Alliance. Professor Ramaiah served as chair for Sub-Saharan Africa Region International Diabetes Federation from 2000 to 2006, and then as vice president of the global vice president for the IDF from 2007 to 2012. He was appointed honorary professor of medicine and global health at the Liverpool School of Tropical Medicine in November 2018. Professor Ramaiah greatly contributed to a better understanding of diabetes in the African region. He has invested in the status of diabetes care in Africa, the economic cost of diabetes, and its consequences. At present, Professor Ramaiah is working with children who have type 1 diabetes, gestational diabetes, metabolic syndrome, and cardiovascular complications of antiretroviral treatment for HIV, as well as its interaction with TB and diabetes. Together with NIMRI and the Liverpool School of Tropical Medicine, he's working on communicable and non-communicable disease integration models, which is the MOCA study, and will be overseeing metformin interventions in HIV patients with IGT, the META trial. He has also participated actively with other colleagues in several platforms, including the Ministry of Health and TAMISEMI, to implement diabetes NCD program integrated programs at zonal, regional, as well as district hospital levels across the country. This program has now obtained additional funding to expand to encompass NCD prevention and promotion, curative services in primary care, training, policy, and legislations, as well as monitoring and evaluation and operations research. Please join me in welcoming Professor Ramaiah, who will speak to us about the historical perspective, current situation, and recommendations on secondary and tertiary prevention of NCDs among recipients of care living with HIV in Tanzania. Karibu, Professor.
Yeah, thank you. Thank you very much for that introduction. And if I can. Yeah, I was asked to talk about the historical perspective. What's the current situation and recommendation on secondary and tertiary prevention of NCD among the people with HIV? I don't know, what's the flow? Oh, next slide. Okay, next slide, please. So if you look at the background, next slide. This is just to give you an overview of what is happening. If you look at 2003, HIV, people living with HIV were 25 million, well-controlled were less than 5%, new cases were 3 million per year, and premature deaths were 2.3 million. If you look at 2021, HIV, people living 26 million, well-controlled more than 80%, new cases less than 1 million, premature death less than 500,000. Look at diabetes in 2021, 24 million living with it, less than 5% well controlled, 1 million new cases per year, premature deaths about 500,000. And if you look at hypertension, 100 million people living with it, less than 5% controlled, new cases 3 to 4 million per year, premature death about more than 1.5 million. And you can see what has actually happened and what is evolving now. Next slide. So if you look at THD risk factors in people infected with HIV, you have the lipids, which are due to the antiretroviral therapy. You got the age, gender, and family, which is a non-modifiable risk factor. You got inactivity, diet, obesity, cigarette smoking, hypertension, hypoglycemia, and insulin resistance. And all this actually contributes to the risks in people with HIV. Next slide. Yeah, and what you have is, again, HIV infection per se also is supposed to be toxic, and it also causes cardiovascular effect. ARTs with a different form of ART, especially second, third line drugs, might cause you the difference. Currently, with the first line, with the gravir, I think we have the same issue whereby you get sudden increase in weight, obesity does come in, and if you are not careful with the lifestyle, then you start precipitating other problems. Like, so the concept of what we talk about multimorbidity came from South Africa. This was published in 2015. And if you look at overall multimorbidity, it was around 22.6%, and 4% had more than 2 conditions, and 5% had 3 conditions. And if you look at the clinic in hypertension clinic, you find there were people with diabetes, HIV, and TB who were not diagnosed. If you into the HIV clinic, you had patients with diabetes, hypertension, and TB who were not diagnosed. Similarly, in diabetes clinics, you had people with hypertension, HIV, and TB who were not diagnosed, and in TB clinic it was the same. So this was the first perception of that there is something going wrong with this, and we are morbidity. Slide. So the data which has come in recently, whereby you find that what is a non-communicable disease burden, and if you look at 2015 compared to 2035, in people who are HIV positive and HIV negative, you find that by 2035, we expect more than 50 to 60% of people living with HIV CD burden. It could be 1 risk factor, it could be 3. Next slide. Again, if you look at overall, what are the NCDs which are very common in people with HIV, you find that there is invasive cervical cancer, there's obesity, diabetes, hypertension, and different types of dyslipidemia. And now it's, even the mental health is being picked up in this patients. Next slide. So, talk about integration. Next slide. So, if you look at integration, you basically, based on the pillars of WHO, you want to look at the service delivery. You want to improve the level of health, you want to improve the responsiveness, adherence, compliance, you need to give social and financial risk protection, and you want to improve the overall quality of care. So when we talk about integration, how are we integrating? Are we integrating NCD into CTC clinics? Or are we integrating HIV-TB into NCD clinics, integrating HIV and or diabetes at a primary care setting? Or are we looking at something else, which includes prevention to child transmission? And next slide. we want to do the integration. We want to do the integration because we want to improve the quality of care, we want to improve the access to care, we want to improve the coverage, we want to make it more cost-effective and cost-saving. Next slide. So the linkages between HIV and NCDs. Next slide. So statistics show that in 2019, Systemic Review reported prevalence of depression among people with HIV was 31%. These people with HIV had twofold increase in cardiovascular risk factors compared to HIV negative population. Women living with HIV have sixfold increase in risk of cervical cancer. Cardiovascular disease is the leading cause of non-AIDS related morbidity and mortality in people with HIV. The global burden of CVD among the people living with HIV has tripled over the past 2 years, and Africa and Asia Pacific region. And yeah, 86% of them have a premature NCD death occurring in low and middle income countries, and the prevalence of tobacco smoking is much, much higher in HIV positive population. Next slide. So these are the references for all this data. Next slide. Again, within the Tanzanian setting, are we ready to manage the NCD at the primary care? And if you look at this data, this is from the SARA survey, which has been done, and if you see the readiness of these facilities to offer non-communicable disease, you find that diabetes, 54% of the facilities can offer diabetes care, 49% cardiovascular disease management, 42% chronic respiratory disease, and then 72% cervical cancer screening. And that 72% is high because cervical cancer screening is integrated within the HIV and the CTC clinics, and that's why you find that levels are high. So if you are talking about integration, this percentage needs to be improved. Next slide. What are the secondary and tertiary preventions which we can do once we have the integration in place? So if you look at benefits of lowering blood pressure, you find that if you control the blood pressure better, then your stroke incidence goes down by 40%, myocardial infarction by 25%, and heart failure by more than 50%. Next slide. If you look at the benefits of managing this hypertension, then you find that over a period of 10 years, you will actually save 1 person out of every 11 people who have hypertension, and they are basically, there's a net effect which you see over a period of time. Next slide. Again, if you look at diabetes, and if you manage diabetes well, next slide please. If you manage diabetes well, and if you are able to control, with a good control, with a single reduction of HbA1c, you see that you are actually reducing the peripheral vascular disease by 43%, microvascular by 37%, cataract extraction by 19%, heart failure by 16%, myocardial infarction by 14%, and stroke by 12%. So when you look at the combination of using hypertension and diabetes in a person who has got this multimorbidity, you find that the net effect of saving these individuals from the morbidity and mortality is very high. Next slide. What is the way forward? Next slide. If you look at the cascade of management of HIV and NCD, you're looking at prevention, you're looking at diagnosis, you're looking at enrollment into care, you're looking at management of the disease, and then in terminal cases, you are looking at palliative care. And if you look at both the sides, I think the only difference is the virus, otherwise the systems are the same. Next slide. So this is the model which we are trying to implement at the primary care, having a common triage where at the primary care level, as soon as you enter, you actually have your screening done of body mass index, blood pressure, blood glucose, provider initiative HIV, counseling, testing, and TB. And then based on that, at the health center level, you can do health education, you can go into health education programs, school health programs, community using community health workers, and then going into what we call as a disease-specific services. Next slide. Thank you very much.
Excellent, thank you so much. Next on our list, I wasn't out of time yet, is presenting from THPS, Dr. Ola Farid Jahanpour, a medical professional with over a decade of experience in public health, research, and evaluation, serving as technical advisor for research and surveillance at Tanzania, at THPS, as she also pursues her PhD. Her expertise spans academic as well as implementing partner contexts, making her a valuable asset in advancing healthcare initiatives in Tanzania. She's also a mother of 2 boys and a passionate advocate of breastfeeding, believing that, among other things, it plays a vital role in preventing NCDs. Please join me in welcoming Dr. Ola Farid, who will talk about the burden of NCDs among recipients of care in HIV prevention and care treatments, clinics in Pwani, Shinyanga, and Kigoma. Karibu.
Thank you very much, Dr. Eva. Good afternoon to you. Tanzania Health Promotion Support is a local non-governmental organization that was established in 2011. Currently, we are implementing a number of projects. One of them is Afya Hatua, and I'll be presenting the learnings that we've acquired from project implementation. So, as mentioned, the topic is going to be on the burden of non-communicable diseases among recipients of care in HIV prevention care and treatment clinics in Pwani, Shinyanga, and Kigoma, where Afya Hatua has been implemented. Currently, the program has been extended. We are now in Tanga. Next slide, please. So, earlier this year, THPS leadership set out to integrate NCD services at the care and treatment clinics. We had questions about available data, about the burden of NCD among the recipient of care. We also wondered how integration would actually look like, and also resources that were needed to achieve this goal. Next slide, please. So to achieve this goal, we started with assessing our strength. First and foremost, we were committed to integrate the services. We is the THPS leadership, staff, region and council, health management teams that we work with, and also site providers were aware of NCD screening, diagnosis, and management from their professional trainings. We have established a client flow at the sites, which could easily accommodate NCD integration. Also, we had received revised CTC2 cards and database, which had included NCD items. And sites had the necessary tools that were needed for weight, heart, and blood pressure measurement. Also, the sites, and after a tour, had a system to assess the essential medicine that are needed. Next slide, please. So to move towards NCD integration, we engaged with providers, and we also did site visit to understand on the potential challenges. One of the challenges that we identified was negligence. And by this, we mean that some of the providers did not prioritize height, weight, and blood pressure measurement of our recipient of care. Another was the shortage of staff at some of the facilities, and this then made it difficult for the provider to take the necessary measurements. We also noticed there was poor documentation, and by this we mean there was inconsistency between what was recorded in the CTC2 database and what was recorded in the cards. And some sites still had the old CTC2 cards, which missed the columns on blood pressure measurements. And some of the facilities that we visited, we noticed that they were faulty equipments and that required repair or replacement. Next slide, please. So to achieve NCD service integration, the approach that we used, we started to collaborate with experts in the field, some of whom are on the panel today. And next slide. We established a dedicated team to coordinate the NCD efforts. This team received the training, and also all the THPS technical staff went through an online training on cardiovascular disease, non-communicable diseases. Next slide, please. We also mapped available equipment for the necessary measurement at the sites and ensure that all the sites had the necessary equipments, either by procuring them, repairing them, or redistribution of the available equipment. Next slide. And we also we sensitized the providers on NCD integration and provided the available job aids. Next slide. As early as February this year, we started weekly monitoring of documentation. Does this one work? Weekly documentation or weekly monitoring of documentation of weight, height, and blood pressure. It's worth noting that with regard to blood pressure, when we started off, only 3%, thank you. Oh, it does not work on the screen. So only 3% of our recipient of care were actually having blood pressure measurement. Next slide. And the regional head came up with the scale-up plans or to improve NCD integration, which included training of the providers together with mentorship and supervision. Next slide. We also integrated NCD across other services, such as the voluntary medical meal, circumcision, and also in other projects that THPS is implementing, such as police and prison. Next slide. And this is our achievement. So for this analysis, we have used data from the CTC2 database, and we have included only adults age 15 and above. And if a person made more than one visit, we took the latest visit. So as you can see, as from March to September, almost all of our recipients of care have their weight measured. Next slide. With regards to height, when we started, almost a half of the clients had their height taken, and as of September, over a quarter of them have their height taken. Next slide. With blood pressure measurement, when we started in March, about half of the clients had their blood pressure measured, and as of now, we are at 90%, over 90% of them with the blood pressure measured. Next slide, please. So we use the weight and height to calculate the body mass index. As previous presenters have mentioned, this is a risk factor for developing non-communicable diseases. And you can see over 40% of the clients have abnormal body mass index. Next slide, please. And also about 6% of them have elevated blood pressure based on one recording. We didn't do multiple recordings. Next slide. So THPS is really committed to integrate non-communicable diseases in its service. And as a way forward, we are working with CDC to see how to provide antihypertensive treatment to some selected sites as a pilot study. Thank you very much. Next slide.
Thank you so much, Dr. Ola. Now, I have a small treat for you. Next, tuna wageni ambao watapenda kutushirikisha uzoefu wao katika kupata huduma. Kwa hiyo naomba nimkaribishe dada Noela awasogeze wageni wetu ambao wako tayari kusema nasi kwa Kiswahili. Watajitambulisha kwa majina yao na mahali wanapotoka na kutushirikisha. We have two visitors from recipients of care from our clinics who are ready to share with us their experiences in receiving care for HIV as well as non-communicable diseases. Karibuni. Tajitambulisha na kuzungumza kwa kifupi.
Asanteni sana. Mimi kwa jina naitwa Nuruhimu Omari kutoka Shinyanga Mwadui. Mimi niligundulika na hili tatizo mwaka 2009 mpaka kufikia hivi leo nina miaka 15. Na naendelea na huduma, natumia dawa zangu za ARV kila siku na naendelea vizuri. Kwa hiyo nawashauri wenzangu msikate tamaa unapogundulika na hili tatizo ndio ukajua hivi ni mwisho wako wa maisha. naomba ukishapewa ushauri na madaktari utumie dawa jinsi madaktari wanavyokushauri. Ilipofika mwaka 2021 niligundulika na tatizo la pressure. Nilipogundulika madaktari wakanishauri na nikaendelea kumeza dawa mpaka sasa. Kwa hiyo kuanzia mwaka 21 mpaka leo 2023 na miaka 3 natumia dawa za pressure.
Jina langu naitwa Juma Baingai, ni mwelimishaji rika katika kituo cha afya Uvinza. Niligundulika mnamo mwaka 2000 nilipopata tatizo la maambukizi ya virusi vya ukimwi. Nilipata ushauri wa madaktari, nikaanza ufuasi mzuri wa dawa, ambapo mpaka sasa nina HbL chini ya 20. Mwaka 2020 niligundulika kuwa na sukari, ambapo nilikuwa nikipata kizunguzungu mara kwa mara, nikiishiwa na nguvu mwilini. Nilipoenda kupima wakaniambia nina sukari, ilikuwa ni 31.9, lakini mpaka sasa madaktari wamenisimamia na mimi mwenyewe nikijisimamia, wamemonti mpaka kufikia 7 ambayo nimepima juzi. Ikiwa mwelimishaji rika, zipo changamoto ndogo ndogo ambazo zinatusibu na hasa mazingira rafiki ya kufanya counseling. Kwa hiyo ni waombe wadau wetu kuendelea kutusimamia na kutengeneza mazingira mazuri ambayo tunaweza tukafanya counseling ya mtu na akaelewa kwamba tunachokiongea ni nini. Licha ya kwamba unafanya counseling, mtu anaingia, mtu anatoka, hata yule unayemfanyia counseling anaingiwa na hofu kwamba labda hawa wamekuja kunichunguza mimi au namna gani. Kweli niwashukuru sana madaktari wangu, niwashukuru THPS ambao kupitia daktari wangu Madina na wengine wote waliweza kunimonti na mpaka sasa ninaishi nikiwa na miaka 62. Asanteni sana.
Thank you. That was just to share how real the situation is. Coexistence of HIV and non-communicable diseases is there, and we need to address it. So our next speaker is none other than my former employer, Dr. Mahesh Swaminathan. He serves as the country director for CDC in Tanzania, leading the agency's broad health programs in the country. Prior to joining CDC Tanzania, Dr. Swaminathan served as the CDC country director in Nigeria from 2017 to 2021, where he led CDC's global health portfolio, including HIV, global health security, TB, and immunization. Dr. Swaminathan also guided the technical priorities, program strategy, and implementation of CDC's HIV and TB programs in Nigeria. Dr. Swaminathan started his career with CDC in 2010 as an Epidemic Intelligence Service Officer with the Division of Global HIV and Division of Global HIV AIDS, DJHA at the time, clinical surveillance team. After his 2-year fellowship, Dr. Swaminathan continued with the clinical surveillance team, which is now a part of the Global Division of Global HIV and TB from 2012 to 2017. He was promoted to lead a team in 2014, where he worked to strengthen HIV case surveillance and other routine surveillance modalities for tracking the global HIV epidemic. Dr. Swaminathan's technical leadership at CDC and within PEPFAR was critical in providing guidance and models for using routine programmatic data for surveillance and measurement of programmatic impact. Dr. Swaminathan received his undergraduate degree in bioengineering from the University of Pennsylvania and his medical degree from Jefferson Medical College in Philadelphia, Pennsylvania. He completed his residency in internal medicine and fellowship in infectious diseases at Mount Sinai Hospital in New York, New York. Please join me in welcoming Dr. Mahesh Swaminathan, who will speak on strategic investments towards integrating NCD services in HIV prevention, care, and treatment.
Me to speak, and also in particular thank you to the patients who talked a bit about their experience being able to manage both their HIV as well as hypertension. Next slide. So while the next slide is coming up, the previous speakers have talked a bit already about the burden of burden of hypertension. Actually, it's funny. When I started my career, HIV medication wasn't actually that widespread. And over time, my patients, this is true here, what I often say to them now, especially now that the medications are easier to take, well, the good news is that you're not going to die from HIV. The bad news is, well, you're going to have all the other problems that the rest of us have, right? So that includes things like hypertension, diabetes. Now our patients have to stop, they shouldn't smoke. They have to stop smoking, right? And so really it's natural that we can see that there's been an increase in non-communicable diseases among people living with HIV. The data that you see here from the Africa study, which is a cohort actually in multiple countries around the world, that follows people living with HIV on treatment, shows that there has been a significant increase in non-communicable diseases, particularly associated with increasing age. If you take a look at the green column, which is men 50 and above, and the purple column, which is women 50 and above, you can see that both men and women living with HIV are, as they get older, are experiencing increases in non-communicable diseases. Next slide. So once again, as we, as those who work in HIV get better at our jobs, we make sure that patients have their virus suppressor taking medication. Now you have to think about, well, how do we help them live well with HIV? How do we make sure that they have both a normal lifespan, but also a healthy lifespan? Once again, we're now talking about, for people living with HIV, the same challenges that people living without HIV have to deal with as they grow older. Next slide. And so now in PEPFAR, through its country operating plan guidance in our fiscal year 23, recommended screening from non-communicable diseases as well as treatment through integrated healthcare models. And that ideally, antiretrovirals should be provided in the same place and by the same providers who also provide chronic medication. And by the way, I just have to say that in many other countries, this is the case. So when I was doing my training, for example, in the United States, as a both internal medicine and infectious disease boarded physician, I had to manage my patients' hyperlipidemia, their tobacco use, their blood pressure, and so forth. So this is something that's not really new. Next slide. So CDC Tanzania, we're trying to integrate management of non-communicable diseases in our HIV programming. So for example, blood pressure screening. Now, it's interesting that we're talking about blood pressure screening. I would argue, and I've been pushing this and I'm finally succeeding with our partners, that there's a reason why we call blood pressure a vital sign. Anytime any of us see a physician or nurse or other provider, we must have our blood pressure taken. And so really this is not a huge stretch. Not only is this important for diagnosing hypertension, but also just good medical practice. We also have been integrating HPV vaccination for girls living with HIV, and we'll talk a little more about that later, as well as cervical cancer screening and management, including visual inspection and use of acetic acid for treatment. And then finally, facilitating referrals to services for people living with HIV with signs and symptoms of NCDs. And we talk about referral because our program is supported primarily by PEPFAR, the President's Emergency Fund for AIDS Relief, and there'll be a session on that at 4 o'clock. Our funding is primarily for the management of HIV, and so we do have limits in terms of what we can procure to provide services for non-communicable diseases, but that doesn't mean that we can't refer patients, and it also doesn't mean that the programs that we support can't be a venue for patients to receive services in an integrated and safe way. Next slide. So you heard a little bit from Dr. Ola about THPS's work in terms of supporting the screening for nutritional status as well as hypertension among all patients in their regions. This is something that all of our implementing partners will be doing, though, and we'll talk about this later, there are a few places where we may be able to actually procure medication and provide it. And any of those who are found to be overweight, obese, or hypertensive are then linked to appropriate services. Next slide. So in collaboration with the government of Tanzania, we will be implementing an integration project, implementation demonstration project, integrate hypertension management, not just screening, but management with the prescription of medications in 4 regions and selected facilities from starting October 2023. And this will include capacity building for healthcare workers in hypertension management, coordination, supervision, and prevention of antihypertensives. And we're hoping that the lessons learned from this will then inform the national strategy. And I really want to give credit to Dr. Kaushik, who really helped us think through how to implement this project. The idea here is that with 2 or 3 antihypertensives that are available in Tanzania and are relatively inexpensive, that the vast majority of patients can achieve well-controlled hypertension. And I have to say that for those of you who are interested, you can always go to the website of Resolve to Save Lives, Dr. Tom Fried's NGO, which is supported by Bloomberg. And there you'll see that there are many other countries that have actually been able to show that this can be done. Next slide. In terms of preventing cervical cancer, we have already started to support HPV vaccination among girls living with HIV in all regions, in all the regions that we support. We started in May 2022. However, the government of Tanzania is already now taking the lead in terms of really broadening this effort. With support with Gavi, I believe that the Ministry of Health is planning on implementing more wide-scale HPV vaccination in calendar year 2024. And CDC is well poised and their partners to support that effort. What I will say is that I do think Tanzania is in a good place and has the ability to eventually eliminate cervical cancer. I say eliminate because there will be people who are older women in particular who are not eligible for vaccination who've already been infected with HPV. However, now that we're talking about really broadening vaccination, doing multi-age cohorts, we really can make a dent in this disease and really make sure that very few women are afflicted with cervical cancer moving forward. Next slide. And as I noted earlier, we are working with the government of Tanzania through our implementing partners to support the screening of cervical cancer and the treatment of precancerous lesions. This work should continue, but I'm also hoping that as we move forward with the ambitious scale of HPV vaccination, that this type of work will become less and less necessary. Next slide. So just in terms of moving forward, we're going to continue to work with our government of Tanzania colleagues as well as our implementing partners to ensure that non-communicable disease management is integrated into HIV care. And I just want to say that one of the things I think that the HIV program has really done is, yes, HIV is a communicable disease, but HIV is also a chronic disease. And in terms of the management of HIV, it's not simply enough to provide antiretrovirals, but also requires a whole system around that patient in terms of adherence counseling, in terms of encouraging behavior change, in terms of helping people live with their disease, that is not dissimilar to what has to be done when someone is diagnosed with hypertension or diabetes or hyperlipidemia. For example, I was diagnosed with hyperlipidemia a few years ago, and yes, you may not tell, but I am trying to live a healthier life, and I can see that the challenges that I have had are not dissimilar than what people with HIV or people with diabetes need to deal with. That the life that you led before has to change in order to make sure that you live a longer and healthier life. So I'll stop there, and thank you very much for the opportunity.
The last speaker on our panel for today is Dr. James Tumaini Kengia, who works with PO-RALJ, the ministry under the President's Office, as coordinator for research and publication. He is an experienced public health specialist with demonstrated history of working in the hospital and healthcare industry in general. Dr. Kengia is a principal dental surgeon with a postgraduate diploma in hospital management that was part of an international leadership training in hospital management that was supported by the government of Germany by then. He also has an MBA for medical doctors from the University of Applied Science in Germany, a PhD in public health leadership, majoring in healthcare economics from Tokyo Medical and Dental University in Japan, under the scholarship of the Japanese government, mixed scholarship, and a postgraduate diploma in leadership organized by the Uongozi Institute in partnership with Aalto University of Finland. He has also worked as a member of the Regional Referral Hospital Management Team and Regional Health Management Team, and as acting regional medical officer for Mwanza Region, and principal investigator and director for Mwanza HIV/AIDS Service Provision Project. While working within the region and PRALG, he has been involved in planning, coordinating, providing supportive supervision, and monitoring and evaluation of health services. Currently, he is involved in teaching as an adjunct lecturer in health systems management for Master of Science public health students at the University of Dodoma. In the University of Dodoma, he particularly teaches planning, organization, change management, resource management, leadership and management, monitoring and evaluation, and introduction to health economics. Please join me in welcoming Dr. Kengia, who will speak about, his topic is Towards Achieving Universal Health Coverage, the government's approaches to ensure sustainability of the treatment and rehabilitation of recipients of care with NCD comorbidities. Karibu Daktari.
Thank you very much, the moderator. So my job is really very small. Building from the previous presentations is actually to link the issue of universal health coverage, some strategies for sustainabilities, when we're discussing now the issue of treatment and rehabilitation for people living with HIV/AIDS with NCD comorbidities. Next slide. So I'll just talk in those 4 areas, a bit of background of UHC, status of NCD services, in particular at the level of the primary health care, some bit of unfinished agenda, and conclusion looking into the future. Next slide. So just to have a common understanding, talking about UHC, universal health coverage, we are really interested in ensuring that we have access to all the services, building from the promotive, preventive, curative, and rehabilitative services. But the issues of effective coverage is very important, and of course, guarantee people not to succumb to catastrophic health expenditure is also necessary. Next slide. So you see that as we're discussing on UHC, NCDs, HIV/AIDS, and integration issues, the issue of equity in access is critical. That's point number 1. But of course, the second thing is the issue of guaranteeing the quality of services and financial risk protections. But in most of the cases, when we're discussing about UHCs, usually people overemphasize on the demand side. In particular, we are discussing about UHI, universal health insurance, a lot. But we forgot that as we're discussing about universal health coverage, also the supply side area is also very important. Next slide. So building from Tanahashi chart, health coverage, at the middle there, we are talking about utilization of services here. The issue of integrated care, that is important. But on the left side there, number 1 there, the availability of services is critical. That is number 1 is important areas, including the issue of HR, qualitative and quantitative, about the availability of staff in our areas, in the facilities, the issue of health commodities and medical equipment as highlighted in previous presentations, but also, as we are talking about equity issues, how our facilities are really located countrywide, that is critical. Then you have the accessibility and initial utilizations, then people will really consume the services towards the adequate coverage, and our interest at the end of the day is to have the quality services, the effective coverage. Next slide. So if we now reflect these models in our healthcare systems, you will realize that it is very important now as we are discussing of integrations and universal health coverage for NCD services and HIV services, the important entry point is PHC, primary health care. That is critical. And the second, why? Because this is like a quick win among the other options. There's a lot of evidence. If we can enter through PHC, we're able to have a larger impact. Next slide. So why we're talking about PHC is because really more than 95% of health facility in Tanzania are really coming from the PH levels, talking about from dispensary to the level of the district hospitals. But of course, at the base, in Tanzania's care system, there's a community, which is also within the PHC, yeah, the local government authority there. Next. So that's the 95%, the PHC. Next slide. So if now we look into the primary care in Tanzania, trying to explore the landscape in terms of the provision of services, you realize that out of those facilities that are operating nowadays, 793 by September, we have 278 health centers have established NCD clinics. I think just back the previous slides. Yeah, this one. So out of those facilities, 7,015 public facilities, we have a number of them which are public, around 6,000. But of course, we also realize the importance of private sectors as part and parcel of the PHC. But as a key takeaway message for the district hospital now, out of all those 173 district hospitals, all are also having the NCD services. But out of 173 district hospitals, we have 67 district hospitals that have a dedicated diabetes and hypertension clinic that is provided once every month. And also with 8 district hospitals that have started sickle cell disease clinics. So you can see a couple of kind of opportunities for the integration of services, because we already have those kind of services. The next slide. So for the health centers, the status quo to date is we are talking about 278 out of 793 health centers. They have established NCD clinics, mainly diabetes and hypertension, and we have, but nowadays at least all the health centers, you will have at least one medical officer. Even the most rural area in Tanzania, we have placed some medical officers there and nursing officers. So those are some of the opportunities for integrations because of the capability in terms of the skills and likes. And in addition to that, with Tanzania Diabetic Associations, a total of 2,778 healthcare providers from 702 health centers have been trained to provide NCD services. That is our additional qualities when we are discussing about integration of services. And the other things that financial resources is important, but the good thing that is also an opportunities within our planning tools, the CCHP, Comprehensive Cancer Plans, and also the facility plans. We have a dedicated priority areas for non-communicable diseases. Priority area number 4, and of course, for the infectious disease, communicable disease, priority number 3. So those one, we are able now to budget some of the issues. And of course, at the level of the facilities, with the health facility plans, we are now also directing the resources, the financial resources to the level of the facilities, the asset and the dispensaries. That means we also are able to plan and accommodate some of the resources for the implementation of the intervention that we're talking about. Next slide. So what are the unfinished agenda as we are discussing, also reflection with the previous presentations. I think we also need to have some kind of a common understanding and agreement building from the previous studies that came out, like Respond Africa and the like. They've shown already that integration of services is important, but also a need now to build from that one with the upcoming also implementation research kind of, that was also talked by the CDC directors, all those one. We would then have to come up with a common understanding about the model operandi when it comes into the integration of services, the how part. Of course, we'll also need to embed some implementation research to have more understanding while we're also implementing, to build a very stronger evidence, come up with the proper guidelines that is standardized countrywide for the implementation, and of course the capacity building, and then come up with the implementations. Next slide. So in conclusion, and looking at the future, talking about integration of services, we cannot forget about the PHC. It's critical here, the primary care as an entry point. But of course, we cannot forget the universal insurance bill, the discussions. That is very important because there's also a demand side intervention that is needed in terms of the ability to pay and the likes. Improvement of quality, we cannot further emphasize on it, but the effective referral system, but also the issue of enhancing data use and research for decision making is important. But lastly, but not least, is the issue of people-centered healthcare. We are talking about integration of services. Next slide. But we also need to overemphasize on the needs of the promotive and the preventive services. Because people, when they are coming to the healthcare facilities, they're ants in the communities without any kind of illness. We need to go there and close the tap so that we do not have people come in the facility with already illness. And we also emphasize also the need not only of the community, but we should not forget ourselves as healthcare workers. That is important under the concept of people-centered healthcare. Next slide. Asante sana. Thank you very much.
Thank you so much. At this juncture, I'd like to invite our 5 speakers to kindly take a seat up front so we can engage in the Q&As and discussions. Thank you so much all for the insightful presentations. We've gone through the basic sciences, the understanding of the situation in Tanzania, what is happening at the site level. We've heard a little bit from some recipients of care. We've heard about the development partners' vision in terms of investments, as well as the local government approach. Karibuni, please. Please raise your hand if you have a question or a comment relating to this topic, so you can get a microphone sent to you. Do we have another one in the room? Let's start with 3 questions, and then we'll take some responses and take another set. So sitting up front is an advantage. 1, 2, 3.
Thank you very much for very nice presentations and very nice topics. My name is Chako Halfan. I'm basically an oncologist. I have one interest, and my interest is how we define primary healthcare in our settings. Because from the presentations of my colleague there, it seems even the district hospitals, the health centers, and all the primary health care. But when we compare in other parts of the world, for example, maybe UK, the primary health care is where a client is first seeking a medical care. And can be a family physician at a family level, or can be a nearest health facility that a person can go, that the primary, the lowest referral of the healthcare. But me being oncologist in the past, for example, you can find a person who is dispensed before being diagnosed with the disease, maybe 6 times. Then you refer to health center for another 3 months, then to hospital, spend another maybe 3-4 months, then regional hospital, then Muhimbili, then to Ocean, actually spend like 3 years. Therefore, my advice is we need to refine our primary health care. Otherwise, we're going to face a big problem in the future. If we consider hospital, which is maybe in the 3rd level of the referral system, is a primary health care, that's not a primary health care as far as it's concerned. My thinking is maybe a family, those people, what we call healthcare workers, those community healthcare workers, probably in dispensaries, we can define them as primary healthcare, not health centers, not district, not regional hospital, or not even the national referral hospitals. Thank you.
Patrick.
Thank you very much. I'm Patrick Inemo. I work for Pathfinder, Tanzania. I have a question, and probably picking from Dr. Chakuo here, just to really tease out and ask what more can we do? So we know that we have a limited human resources for health, but what more can we do? What opportunities are there for things like task shifting to the community workers to perhaps at the community level. Issues of repeat prescriptions, perhaps having patient group care directions, protocols which can be used by these lower cadre of what more can we do, or what is being done now, and what more can we do? Thank you.
Thank you. I'm Matthew Kawogo. I come from the National Council of People Living with HIV. Thanks for the good presentation, the last presenter in particular. I'm concerned about sustaining healthcare services, particularly primary healthcare, with the fact that we at large depend on donor funding, which recently we see diminishing. If I take statistics from the AIDS Trust Fund 2 years ago, it looks like still over 95% of the funds for HIV is coming from the donors. And we are seeing the funding going down. I think Doctor from CDC can prove that. So how do we connect sustaining primary health care services with the resources diminishing and the fact that we are depending on donor funds? That's number one. And number two, if I'll be selfish, then what's the best way of engaging the communities, particularly people living with HIV, in addressing some of the non-communicable challenges which are non-medical? We know that they have a role, and what do you advise on that? Thank you.
I'm made to understand we only have one microphone, so I'll take two more questions. I saw Mariana and another hand at the back.
Thank you very much. I'm Mariana Balampama. I work with PACT as Deputy Regional Director for Africa. Mental health conditions have also been mentioned as an important comorbidity for people living with HIV, but I haven't heard as much in terms of what is being done and what can be done. I would love to hear from the speakers, in particularly Dr. Kaushik and Dr. Ola, from an implementation perspective. How is mental health being integrated into care for people living with HIV? Thank you.
Thank you. My name is Dr. Caleb Joel. I work for MST as a System Strengthening Manager. And I would want to congratulate THPS, CDC, and PEPFAR for the special interest for the people living with HIV and NCDs. And my worry was some of our facilities which we are supporting are dispensaries. That means they are deprived of the human resources and the capacity to diagnose as well as manage the non-communicable diseases, especially diabetes and hypertension. So what are we doing to ensure that the client who is at the primary health care get the best management on top of the capacity which is available, and we're not imposing him with an extra cost on buying the medications which are now not being supported under any VETCO program? Thank you.
Thank you so much. I'll now invite our panelists. Dr. Ola, would you like to start?
Thank you very much for the questions. I think I had two. One on mental health. Yes, we as THPS realized that mental health is important among people living with HIV. And when we started our efforts to integrate NCD services, we also considered that. So, but we decided that we'll have to start with what we felt it was easier to start with hypertension, because as Dr. Mahesh mentioned, blood pressure is one of the vitals. So we felt that there was no excuse for people not being taken blood pressure as a vital. But we realized that we need to expand the scope of the non-communicable diseases that are offered are integrated at the CTC. So when we provided the training to the men as part of their training. So that's one. And on the question on what are the best ways to manage the people living with comorbidities without adding more cost to them. Yes, we understand that as one of the barriers, and us as THPS, when we started these efforts to integrate the services, we are asking ourselves, we will identify people with these comorbidities. What will we do to them? What if they cannot manage these, afford to pay for these other management? So we are also thinking of how to be able to do it. One of the options that we are considering is to encourage majority of them to join the health insurance packages that are available as one way of handling that. Thank you.
Thank you, Dr. Ola. Dr. Mahesh, did you have anything that you'd like to comment on?
Yeah, thank you. I think that maybe I'll just speak to the issue of staffing and sustainability. I think that I think there are a few things here. I think one is Dr. Ola did mention the importance of insurance schemes. One way to ensure that there is money and funding available to support, for example, the procurement of medication and the paying of providers is to have some type of universal health insurance of some sort. And so I know the government is thinking through how to set up those schemes, but I think from a revenue standpoint, I think that's really critical. But I think the second thing, though, is really thinking through how services are delivered and by whom. One of the things about medicine is that medicine, in my view, has resisted a lot of the productivity gains that other industries have experienced, right? So phones, if you compare that to the phone that you had, let's say, 8 or 10 years ago, in fact, the phone you have is certainly more powerful than the computer that I had when I was 11 years old. And medicine has resisted that in part, and I think in part it's because we still haven't adopted more efficient ways of providing services. And one of these areas I would say, particularly for medical doctors, is that our role may have to move away from, yes, we still have to provide direct patient care for patients with complex diseases, but maybe much of our work should at some point move to supervising community health care workers and nurses who are providing medical services for diseases that have significant morbidity and mortality, like HIV, hypertension, but maybe those cases aren't that complex. For example, now with HIV, 1 pill once a day is enough to suppress viral replication, and the side effect profile of that 1 pill is actually pretty minimal. In regards to hypertension, we know, and we're going to demonstrate this in Tanzania, that essentially maybe anywhere from 1 to 2, maybe 3 drugs at most are needed to control hypertension in the vast majority of people. And those medications don't really have that many side effects, and those side effects are ones that are easily identifiable. Things like lightheadedness and so forth, or can be identified through laboratory results, which once again, the physician or other provider can review without necessarily having to see the patient. So I think that when we talk about productivity and we talk about sustainability, the role of physicians changes. That doesn't mean that physicians are not a key part of the healthcare system, but our role may be that we see patients with complex conditions that can't be managed by somebody else, and in the meantime, we are also managing large groups of community healthcare workers, nurses, and so forth who are providing services, let's say, in the community. Thank you.
Karibu, Dr. Kenkia.
Thank you very much. So I'll talk in two. The first one was the issue of sustainability. That is a very important area, and I think, in my opinion, is we can take care of it in 2 ways. Number one is we are now discussing about integration of services and even the issue of promotions and preventive services in order to cut costs. That's number one. But number two is if you look into National Health Account of Tanzania 2020, then you realize that yes, the donor fund is decreasing, but the domestic funding is increasing if you check that report. But the problem with that report is the domestic fund is increasing is really not within the health insurance envelope. Is the cost, they just pay the cash. So that the problem that the people could succumb into catastrophic expenditure, that's the problem. So the only way is really to increase the pool of the prepayment mechanisms so that we can have a pooled fund that will be utilized for financing the health sector. And when it comes to the question about the PhD definitions, yes, I agree that the first point of entry should define the PHC. But now if you go into Tanzania's care systems, really people will go to the nearby facilities. And with our current landscape, sometimes the first or the nearby facility could be centers or dispensaries or risk hostels. Probably with the matured health system of Tanzania in the in the future, if we have a guarantee point of entry, the nearest to the populations to be a dispensary, then we can redefine. I think something that we will keep on discussing. Asante sana.
Before you move, Dr. Kangia, there was also a question about human resources for health limitations and how that might impact integration of NCD care. Do you have thoughts about the idea of task sharing, task shifting?
I think that we have already the guideline for that one. So with utilizing the guideline, then we can invest upon that guidelines. But of course, also the Minister of Health currently is also moving towards involvement of the CHWs. So there's ongoing discussion on the curriculum in terms of the package of the issue that the CHW will do. So we can also think about accommodating some of the issues that will be done by the CHWs. But also with the ADO, there's some evidence, for example, there's Afya Tech projects that is being done in Kibaha. What they do is really they provide a linkage between the ADO shop and the facilities. So some people with some of the issues, like if they go to the facilities, then the ADO could really do something. So it's also an area that is still under discussion to see how best you can also utilize those people to improve the services.
Professor Kaushik, karibu.
Yeah, thank you very much. I'll start with the first question regarding the primary care. I think primary care within our settings would probably be at a health center level, because at the dispensary level, I think still we need to build the blocks here and we need to get that access. The problem at the dispensary level is that there are more than 6,000 dispensaries. And then even if you are going to impart training and provide equipment and support, it's going to be it is going to take some time. But then at a dispensary level, I feel that it should be the promotion and prevention which should be the focus. And I think from there, with an outreach by the community health workers within the community around the dispensary should be our key, basically, way forward, going forward. So I think we need to get those community health workers. The problem with the community health workers just now is that there are community health workers, but they dependent on projects. They are not systemized. And because they are not within the system, whoever pays them more is the priority. You see? So that you might find that a poor program might not be able to sustain the community health workers because the payment required is high. So I think first we need to streamline the community health workers task force if we want to go for prevention. Second thing is that we need to link them to the dispensary, and then from the dispensary mainly work on early diagnosis and then refer to the higher levels of care. Second thing, I think the advantage of the HIV program, which we have learned from the TB and HIV program, is the tracking. I think they've got a vertical tracking system, and they've got a unique identity number. Within the NCDs, we do not know how many people are hypertensive, how many people are diabetes, because today I might go to one facility, I'll be registered with a different number. I'll go to a next facility, I'll be registered with a different number. So you might find that there is a lot of duplication. So and we do not know what's happening to them because you can't track them. So even if you want to track them and do a longitudinal look at what is happening, unless you are in a study environment, you are not able to track them. So I think what is important is that somehow Ministry of Health and the local government need to come up with a system whereby all these NCD cases have a unique identity number. So wherever they go, they can actually link to those numbers, and then only we'll be able to actually change the outcome. Third thing is, if we are going to do task shifting, we need to have very simple protocols of care. And as Mahesh mentioned, that I think we need to not start with a Mercedes-Benz, we need to start with a Volkswagen, and we need to start with amlodipine, because if you come to amlodipine, they say, amlodipine ini dawa ya zamani, tumia hiyo. But basically, amlodipine still works the best, you see, within the hypertension if you are starting step 1 therapy. So within hypertension, if step 1 is a diuretic, second one is a calcium channel blocker, third one is probably an ACE inhibitor or a beta blocker. And those, if you look at the calculation, it does not cost you more than $60 for a person for a year for the entire hypertension treatment. So I think what we need to be is to be cost effective, but at the same time, make sure that the quality of care which we are providing is at the optimum. Thank you.
And Dr. Mary, we have 2 minutes left.
Oh, thank you. Thank you very much. I didn't have any specific question addressed to me, but I'll come back from the comment from the epidemiology point of view. The first one is really the need for data. As I think there was a session earlier that we were told how the planning and how the resources are allocated, and I think also Dr. Kingia highlighted on that a little bit what they use. So they need all this prevalence data to be able to plan for services across the health system. So I think what we need to do also in terms of integrating, we need to also integrate our data system. So within the routine national surveys that you do, you might need to also include NCD indicators, and also within the main NCD surveys to also include some indicators from all the other programs, so that we are able to link the epidemiological trends of these different diseases. But also in terms of prevention, we had a lot of discussion earlier on when we started the advocacy around NCDs with Professor Kaushik. You have nice linkages in terms of multisectoral linkages within the HIV programming and the national coordination mechanism that we're actually very, very jealous of. And they're like, is there possible to extend that multi-sectoral coordination so that we can also, because you need the same structure to address NCDs in the country, and we haven't been successful. I think it's because of also the funding mechanism it was a bit of a challenge. So I think that for us at a national level in terms of addressing NCDs on a larger scale, it's a platform that probably we could leverage to make sure that we address NCDs in the country. And I would also like to take you back to the slide that also Dr. Kingia showed us. I hope you saw the triangle, that we have more actually health facilities at the lower levels and fewer at the higher level. I can tell you in Tanzania, the prevalence of hypertension is about 30%. So if you, the adult population from 25 and above, we have a lot of patients, but they have only 1,200 patients at the health center. So we need to flip that to make sure that we strengthen the primary healthcare facilities to make sure that majority of our patients, majority of our services are actually provided at the lower level of care. So we need to flip that. And we can only do that through system-wide strengthening, and also looking at the 6 pillars of the health system. So it has to be looked in that way. We shouldn't verticalize it, but because at the same time it's this same patient that will go to the health facility with all these multiple problems. So we need to integrate that within our programming and
Thank you.
our
We are
systems.
out of
Thank you.
time. Thank you all for making time to attend this health forum. We hope it was helpful, it was informative to you, but it has also stimulated thinking around how best we can start addressing the challenge of non-communicable diseases as we also address HIV and AIDS. Thank you so much. I'd like the panel to kindly stay for a group photo. THPS team, karibu for a group photo up front. Group photo, THPS.
It's lunchtime now. As you leave, you remember it is Kilimanjaro, hall third floor.
you.